very much. So did you guys enjoy your little, feast there? So we want to make sure your sugar levels are going up, your cortisol levels have gone up. Maybe we'll get each one of you to come up here and then we'll shoot your cortisol levels really high. So the next in our session in this block about prevention and health promotion, we thought that the innovation here, in addition to all the things that you heard about ECAD and things like that, just as a show of hands, if we're working on the protocol for ECAD, that study where you're trying to treat people earlier with statin therapy, would there be interest here for you guys to participate? How many people would be interested in participating in that? Okay. All right. So it'll be a family doctor run kind of program. So perhaps what you could do is email Shanice, because then we can keep you on the list. So when the protocol is ready, the study is going to be about somewhere in the ballpark of 15,000 patients, and probably will change guidelines when the results come out from that. So it's going to be one of those landmark things done predominantly on Ontario, Toronto, specifically in the surrounding areas, but it would be something for us to all get involved with. So if you'd like to get involved in that, please email us and we'll keep you on our list. Next, we have a talk on sleep apnea. There's lots of things that have been talked about in terms of sleep apnea. And the best person to do this is Dr. Bradley, because basically he's a respirologist and king of sleep, okay? So basically he's a professor of medicine, director of the Center of Sleep and Medicine and Circadian Biology at the University of Toronto, also the Sleep Research Laboratory of the Toronto Rehab Institute, and Center for Sleep Health and Research at the UHN. So therefore, we thought that there's been lots of talk about sleep apnea, so the thought is, let's learn a little bit more about that, because it seems that a large number of patients are affected by this, and it seems to have lots of implications for their health thereafter. So please welcome Dr. Bradley.
Well, thank you for that kind introduction. So today, what I'd like to do is to start off by showing you why sleep apnea is important for cardiovascular health, and then talk about some new work we've been doing which would shed light on some of the work that Paul O. was talking about on exercise and why sedentary living is bad for you, because it actually turns out that it's a risk factor for sleep apnea apart from obesity and potentially treatable. Okay, so why is sleep apnea important in the cardiovascular population? I'll just show you two quick slides why it might be. First of all, it's a risk factor definitely a risk factor for hypertension. We just published a paper showing that if you take patients with drug-resistant hypertension, the commonest secondary cause of that hypertension by far is sleep apnea. About 70% of patients have it versus less than 1% with a pheochromocytoma, less than 5% for renal vascular disease. So it's got to be on the radar screen for treatment of drug-resistant hypertension. Secondly, it's a very significant risk factor for stroke. And third, it's a major risk factor for heart failure. Now, once you have heart failure, it's bad for you. So this slide shows a study that we did, published in JACC in 2007. We took 218 patients to the Mount Sinai Heart Failure Clinic and did an observational study. We did sleep studies on them and found who had obstructive sleep apnea and who didn't. And then we offered patients treatment. Some accepted it, some didn't. And so we followed them up for an average of 2.5 years with a maximum follow-up time of 7.3. And this is a Kaplan-Meier survival curves. And you can see here over this period of time, the red line represents patients with heart failure who do not have sleep apnea. So their mortality rate over this period of time was 12%. The blue line represents the patients with obstructive sleep apnea who did not accept Cpap therapy, and their mortality rate is twice as high, 24%, and that's after controlling for confounding factors, and that difference is significant. The third line is a beautiful, nice straight line up here with no deaths, and that's the patients who had obstructive sleep apnea who were treated with Cpap and continued to use it. Now, it's not quite statistically significant a reduction in mortality compared to this group because there were only 14 patients here, but it certainly suggests the possibility that treating sleep apnea might improve outcomes. But the main thing here is that obstructive sleep apnea appears to be a risk factor for mortality in heart failure. And then central sleep apnea, or Cheyne-Stokes respiration, is basically the same story. So this is another slide from the work that we've done, and what we show here is that heart transplant-free survival versus time. And you can see that the group who has central sleep apnea with Cheyne-Stokes respiration has worse survival than in a group matched for age, weight, ejection fraction, New York Heart Association classification, et cetera, who does not have Cheyne-Stokes respiration. So whether you have obstructive or central sleep apnea and you have heart failure, either one of those disorders is associated with an increased risk of mortality. So that's the clinical significance. Now, we also find that sleep apnea is extremely common in patients with fluid-retaining conditions. So, for example, in the heart failure population, about 50% of patients have sleep apnea compared to about 5 to 10% of the otherwise healthy population. The same is true in renal failure. So what do they have in common? The thing they have in common is fluid retention. So how would that work? So here we take the half-empty bottle, we tilt it on its side, and the fluid layers out, and part of that fluid goes into the neck of the bottle. Well, what I'm going to show you is the same thing is true of humans. We all know that if you take a patient who's edematous, walking around or sitting in a chair, you put them to sleep at night and you wake up in the morning with nice skinny ankles, right? And we all think they pee it out. Well, some of them do and some of them don't. And the ones who don't, the fluid can end up either in the lungs, in which case they probably get Cheyne-Stokes respiration, or in the neck, in which case they get obstructive sleep apnea. And the reason is because the tissue pressure caused by the increased fluid in the neck behind the jaw, so the jaw can't move out, so the only way the tissues can move is in, and that narrows the airway. So during the daytime when upright, fluid is retained in the legs, particularly if you're sitting. And this is a clue. Sitting is a major risk factor for sleep apnea. So the typical person who's not overweight who comes to see me in my clinic is a computer programmer, and I'm going to show you why. So sitting in the daytime causes fluid retention in the legs. Walking doesn't, standing doesn't, but sitting does. And the reason is because you're not contracting your calf muscles. When recumbent while sleeping, fluid retained in the legs redistributes to the upper body. If fluid accumulates in the neck, it may narrow the pharynx, predisposing to its collapse and obstructive apnea, and if fluid accumulates in the lungs, stimulation of vagal irritant receptors may cause hyperventilation that reduces PCO2 below the apnea threshold, causing central apnea. So in other words, exactly the same phenomena we think can cause the two different kinds of sleep apnea that we commonly see in heart failure. So we undertook a number of experiments, and this is the experimental paradigm. We take a subject, lie them down, rig them up for a sleep study or polysomnogram. Then what we did is we put electrodes in their ankles and their upper thighs, and that measures the amount of fluid in their leg, okay, through bioelectrical impedance. And we measured that at the beginning and the end of the night to see what the change in fluid volume of the leg is. Similarly, we measured the circumference of the calf, the circumference of the neck at the beginning and the end of the night to see if there's any difference. And finally, we assessed the amount of time spent sitting during the daytime with a daily diary, the degree of leg edema before sleep. We performed echocardiography to get the ejection fraction, performed blood samples, and did a Duke Activity Status Index questionnaire to find out the level of physical fitness. So the first study we published on this was done in 23 otherwise healthy men referred for suspicion of sleep apnea. They were non-obese and had basically no cardiovascular risk factors and were not on any medications. And what this shows is the change in leg fluid volume overnight. So a negative number means fluid has moved out of the legs and the legs have gotten smaller. Okay, and this shows the change in neck circumference, right? So what we see is as the legs get smaller, the neck gets bigger. So it's like a teeter-totter, right? So it's like that bottle I showed you. So the fluid is actually moving out of the legs into the neck. And that's showing a nice straight line relationship here. So what's that got to do with sleep apnea? This is what it has to do. So here we have the same plot of fluid moving out of the leg, and now we plot that against the frequency of apneas and hypopneas per hour of sleep, which is the major index of the severity of sleep apnea. What we see is a nice curvilinear relationship here, showing that the more fluid moving out of the legs and into the neck, the higher the apnea-hypopnea index. If that's true, that means that if we prevented that fluid from moving there, we may have a new treatment for sleep apnea, and I'll talk about that in a moment. Now, this R value, 0.8, is the highest correlation of any factor ever shown for the severity of sleep apnea. Obesity doesn't come anywhere near to that, neither does neck circumference. In fact, obesity, neck circumference, and other factors account for about 30% of the variability. So this accounts for way more of the variability than all the other factors put together. Why is it curvilinear? Probably because as you reduce the radius of curvature of tube, the resistance goes up to the fourth power of that. So that's a curvilinear relationship, not a straight line relationship. So that's probably what's happening. Now, the question is, what is that fluid movement related to? And the answer is sedentary living. So here we have sitting time. So these people filled in a diary, and it shows here from up here from 4 to 16 hours a day. And we can see as the longer they sit, the more fluid is moving out of the legs at night. So they're accumulating more fluid in their legs. And it was shown in the 1920s through a number of sophisticated experiments that the amount of fluid you retain in your legs is directly proportional to the time you spend sitting during the day. So this fits perfectly with that. So from this, we generated a number of hypotheses. So we hypothesized that in patients with heart failure, the greater the amount of fluid displaced from the legs overnight, the greater the severity of obstructive apnea in relation to an overnight change in neck circumference. The amount of fluid shift is directly related to sitting time and leg edema, and is indirectly related to physical fitness. And Cpap alleviates obstructive apnea in association with prevention of fluid accumulation in the neck. So let's see. So we took 57 patients with heart failure who were referred to our clinic, and we performed the studies I showed you before, looking at overnight changes in leg fluid volume and neck circumference. And we divided the group into those who had mainly obstructive and those who had mainly central sleep apnea. And here's what we found. So this is the movement of the fluid out of the legs at night. And this is a change in neck circumference. So in both cases, we have a nice relationship. The more fluid moves out of the legs, the more of it moves into the neck in both groups. So there's no real difference there. Now, why is that? So this is a study that we've just completed, that we've been doing with Narinder Paul, who's been doing the MRI scans for us. And what we've shown here is the jugular veins, okay, and a subject with obstructive sleep apnea, and that's the blue. So this is the jugular vein as it runs along the side of the pharynx. And the pharynx is a collapsible part of the upper airway where obstructive sleep apnea occurs. And this is a patient who has obstructive sleep apnea, and the volume is 2.1 cubic centimeters. Here's a patient who doesn't have sleep apnea, and you can see that the jugular vein is much smaller. In fact, it's less than half the volume. Okay, and subsequently what we found is the greater the volume of the jugular veins, the higher the apnea-hypopnea index. Similarly, if we look at tissue fluid content in the upper airway mucosa, we find exactly the same thing. The more fluid in those tissues, the higher the apnea-hypopnea index. So that appears to be where the relationship occurs. Now, if we look at CO2, now why do we look at CO2? Well, CO2 is the key thing as far as central sleep apnea is concerned. I don't want to go into nitty-gritty details, but if you drop your carbon dioxide levels below the level required to stimulate breathing, you'll stop breathing. So that's what happens in Cheyne-Stokes respiration. You overbreathe, drop your CO2, stop breathing, your CO2 goes back up, you overbreathe again, and on it goes. So what we found in the obstructive apneic patients is that there was no relationship between the amount of fluid moving out of their legs at night and the PCO2, none at all. In contrast, in the group with central sleep apnea, we find a very nice inverse relationship. So the more fluid that moves out of the legs at night, the lower the CO2. Now we know that if fluid moves into the lungs, it stimulates irritant receptors, juxtacapillary, unmyelinated fibers that are vaguely mediated in the lungs, and that causes hyperventilation. So what we think is going on is the lungs flood with water. The more water they get in the lungs, the more you hyperventilate, the lower you drop your CO2. Okay? And we also know that patients with central sleep apnea have higher left ventricular filling pressures than those without. So that helps to explain the relationship. Now, I showed you a relationship in patients who don't have heart failure or any cardiac disease. There's 23 normal males. And this is their curve that I showed you before. So just see that curve and see how the data from the heart failure patients is exactly identical. So if we take the obstructive dominant group, we see that they fit on exactly the same line as the normal subjects. So the more fluid moving out of the legs at night, the higher the apnea-hypopnea index. And this is the central apneics. So it's the same story, same kind of curvilinear relationship, except it's shifted to the right, and they're moving about twice as much fluid out of their legs at night on average as the ones with obstructive sleep apnea. So what that suggests is that although fluid is moving into the necks of both the obstructive and central apneics, excess fluid, the excess of fluid between this group and this group is probably going into the lungs, causing central apnea. Now notice, again, the tightness of the fit here. The relationship here, the R value is 0.92. I mean, this is pretty remarkable. Okay, so now if we divide them into a group who has an apnea-hypopnea index less than 15, which we would say has no sleep apnea, the obstructive apnea group in red, and the central apnea group in yellow, this is what we see. So this is the change in leg fluid volume overnight. So the ones who don't have sleep apnea have about 100 milliliters coming out of the legs, which is not very much. The ones with OSA have more than twice as much, 235 milliliters, and the ones with central apnea have a heck of a lot more, 404 milliliters. So we're talking about a substantial amount of fluid shifting around, sloshing around at night, as it were. So from this, we've developed a new paradigm for the pathogenesis of sleep apnea, both in heart failure and patients without heart failure. So we start off in the daytime, and we were inactive and sitting around and not doing very much. This causes dependent fluid accumulation in the legs. And then at night, that comes back to haunt us, because this fluid from the legs starts to move rostrally, and it could go either into the neck or the lungs or both. And depending upon where the predominant fluid movement is, you could either get obstructive or central sleep apnea as a result. So then we looked and said, okay, if that's true, we wonder what the mechanism of Cpap is. We always think Cpap is just a pneumatic splint that simply blows the airway open. Well, it certainly does that, but we wondered whether it didn't prevent fluid from getting into the neck, too, because with the increase in intrathoracic pressure, that should prevent fluid from getting above the diaphragm. So let's find out. So this is red represents a baseline study, blue represents a night in the sleep lab while they're on Cpap. So on the baseline night, we can see they're about the apnea-hypopnea index. They have severe sleep apnea with 38 events per hour. This drops to around 13 on Cpap, so it works. And then we said, okay, well, if the fluid movement is primary rather than secondary, so if you have obstructive sleep apnea, you generate a negative intrathoracic pressure, you could actually draw fluid into the lungs or into the neck. If that was the case, then Cpap, if it prevented fluid coming out of the legs, then that means it would be secondary to the obstructive apnea, not causative. If, on the other hand, it didn't influence, it suggests it's primary. So what we found was that Cpap had absolutely no effect on the amount of fluid moving out of the legs, indicating that it's a primary mechanism in all likelihood. Then what we did is we looked at the change in neck circumference overnight. So this is the baseline. And then, while on Cpap, we see a dramatic reduction in the overnight increase in neck circumference. We almost get rid of it. So what that indicates is that Cpap doesn't just work by splinting the airway open, it works also by preventing fluid accumulation. And if that's the case, then there may be other means to prevent fluid accumulation in patients who don't like Cpap. So, conclusion then, nocturnal rostral fluid shift from the legs is a common mechanism in the pathogenesis of both OSA and CSA and heart failure. Similar findings relating overnight rostral fluid shift to severity of OSA in men with and without heart failure suggest that this mechanism applies to across different disease states. We've also shown exactly the same thing in patients with refractory hypertension, and we've also shown it in renal failure. So every single group we've looked in, we find the same thing. Fluid shift into the neck probably contributes to obstructive apnea independently of body weight by increasing pharyngeal tissue or collapsing pressure. In CSA, it appears that some of the leg fluid also shifted into the lungs, where stimulation of the irritant receptors probably contributed to their lower PCO2 and predisposed to central sleep apnea. And thus, the magnitude of overnight rostral fluid shift contributes not only to the sleep apnea severity, but to its predominant type, both of which are linked to sedentary living. Finally, prevention of overnight fluid redistribution into the neck by Cpap is another mechanism by which it alleviates obstructive apnea. Okay, now we all know that salt's bad for you, it's supposed to be, and can contribute to hypertension. Of course, when you have heart failure, we all know patients should be on low sodium diets to try and prevent fluid accumulation. So we said to ourselves, well, look, if salt intake is related to fluid retention, then it ought to be related to sleep apnea too. So with Gary Newton and his colleagues, Gary had a PhD dietitian working with us, and we did a very detailed sodium intake study. And then my fellow Takatoshi Kasai then took the data and we did sleep studies on 57 of these patients. And here we've plotted sodium intake in grams on the x-axis versus the apnea-hypopnea index. And sure enough, we find out the higher the sodium intake in patients with heart failure, the greater their apnea-hypopnea index. And that's probably one of the mechanisms for the higher mortality rate and higher hospitalization rate we find related to sodium intake. So it's making quite a nice story. So these findings indicate that in patients with heart failure, the severity of sleep apnea is directly related to the degree of sodium intake independently of confounding variables. The relationship is likely due to fluid retention secondary to sodium intake and a related increase in overnight rostral fluid shift. And sodium restriction may play a role in the treatment of sleep apnea in patients with heart failure, a possibility that could be tested in randomized trials. Now, as I said to you before, if fluid movement is a cause of sleep apnea, then it may be a target for therapy. So let's find out. So this is a study that was performed by my PhD student, Stefania Rodolfi, in collaboration with a group in Paris, France. And we took a group of patients who had chronic venous insufficiency because of course, they get edema. And, of course, it promotes fluid accumulation in legs during the day and thus could contribute to the pathogenesis of OSA in these patients. Compression stockings are a standard form of therapy for chronic venous insufficiency that counteract fluid accumulation during the day. So we hypothesized that in non-obese patients with chronic venous insufficiency and obstructive apnea, wearing off-the-shelf thigh-length compression stockings during the day will reduce the apnea-hypopnea index by reducing the amount of fluid available for displacement into the neck overnight. So this is the study design. It's a randomized double crossover trial. So we start off with a baseline sleep study. Patients found to have sleep apnea are randomized to a week with compression stockings, a week without. Then a second polysomnogram is performed after 1 week of wearing the compression stockings. On the same night they're wearing compression stockings, and then 1 week later, and then they cross over. Then they cross over to the other side of the trial, both arms. So we studied 6 men and 6 women, mean age 59 years, body mass index within normal range at 26, and I'll just move on to the next one. And what this shows here is the fluid volume of the leg in the evening before they go to bed. So this is in the control period, and this is after the compression stocking period, and you can see that the fluid volume of the leg has decreased significantly. Similarly, the overnight change in leg fluid volume has also gone down, and indeed, the leg fluid volume in the evening has gone down by 150 milliliters, and the fluid movement out of the legs has gone down by exactly the same amount, 154 milliliters. So they're connected, obviously. So then what happens to the apnea-hypopnea neck circumference? So the reduction in fluid movement out of the leg at night is associated with a marked reduction in the change of neck circumference overnight in all subjects except this one. So instead of it going up by 1.1 centimeter overnight, it only goes up by 0.4. So if that's correct, we might expect an improvement in sleep apnea, and indeed that's what we found. So the apnea-hypopnea index has decreased from 48 down to 31, which may not be tremendously clinically significant, but it certainly tells us that this is a mechanism of disease in this particular patient group. So in conclusion, attenuation of OSA by prevention of fluid accumulation in the legs during the day and its overnight shift into the neck via compression stockings provides evidence that overnight fluid redistribution from the legs into the neck is a cause of obstructive sleep apnea. So there's really no doubt about that now. Prevention of overnight fluid shift into the neck is a new therapeutic approach to OSA that warrants further investigation. And if you consider the nuisance of wearing a Cpap machine, many people would find wearing stockings a lot more attractive than wearing a Cpap machine. Thank you for your attention. Yeah, sure.
Are there any questions? And just shout it out, and I think that'd be the easiest way.
Several. What's your opinion of diuretics? How often do you tell your computer expert to stand up and walk around? And does the compression stocking have to go thigh high?
So what is your thoughts on diuretics? And then in terms of your sitting computer person, how often should they stand up? And what was the last one? Thigh high or higher stockings? What is your recommendation?
Yeah.
Knee highs or all the way up,
Yeah.
especially for men
Yeah.
that don't look like that?
Okay, well, in terms of diuretics, I hope not. In terms of diuretics, we're actually doing a study. I was going to show that, but we sort of, there wasn't enough time to go into details. But the long and short of it is we find the same thing with diuretics. The more fluid we get out of the legs with diuretics, the lower the apnea-hypopnea index. And in fact, we're just about to finish that study right now, which is funded by the Heart and Stroke Foundation. And we're doing that in patients with drug-resistant hypertension. And what we're doing is we're taking them and adding spironolactone and metolazone to their regimen, and we're getting this quite remarkable reduction in the severity of their sleep apnea. So it seems to be a general principle. With respect to hot thigh high versus below the knee stockings, Well, the main capacitance vessels of the legs, of course, are in the calf. So in fact, I just today found out we got a CHR grant funded, and one of the studies in that grant is to look at the effects of custom-made below-the-knee compression stockies. The ones we used here were just off the shelf. We think the custom-made ones would probably work better. The question there is, should we gradually decrease their size as the leg gets smaller? It's kind of tough to do that, but we may want to do that. So it probably, we would guess that below-the-knee stockies would work just as well as thigh-length ones. Of course, they're much easier to wear. And the third question was?
How often do you tell your
Oh, yeah, yes. Well, you know, it's hard to say. I didn't have Paul O's data to give them when I see them, but what I basically tell them is they should get up every hour and take a walk down a long corridor. Now, I do that myself. Fortunately, I work in the Norman Urquhart ring of the Toronto General Hospital. It's a 100-meter long corridor, so it's 200 meters each way. I do that, and because most of us, unless we're surgeons working in the operating room all day long, do spend a lot of time sitting. And I'm convinced that it's part of the reason it's bad for you is fluid retention. It's not just a matter of being physically unfit, it's also fluid retention. So I tell them to get up and walk around. I tell them to do simple things like if they have a dog, go walk a dog in the evening, you know, common sense kind of stuff. But it's a little bit early for me to be able to say exercise will improve your sleep apnea, right? We don't know that for sure. There is some evidence that from unrandomized observational studies that indeed higher exercise levels is associated with lower severity of sleep apnea, taking into account confounding variables. So at the moment, I just tell them to get up every hour and walk around, and then walk in the evening when they have time.
So should people with sleep apnea with venous insufficiency be referred for surgery?
Well, that's a good question. I see a couple of vascular surgeons sitting here, looking at their BlackBerry. Rapt attention. So, Tom, what do you think? He must have heard my advice.
You know, it's a hard question to answer. I was wondering how this applied to the lymphedema population that we see who have never complained. I don't hear them complain of sleep apnea.
Yeah.
But I have to say we do a lot of work with them to try to get the edema out of their legs and prevent it from accumulating.
Yeah, exactly.
I heard them talk about sleep apnea that made me think that that might be an interesting connection.
Yeah. So I really can't answer your question, but I think the point is that if you've got any state with edema, you're probably going to have a high prevalence of sleep apnea. So I suspect even though you might not get people complaining about it, if you asked a few questions, you might find out that they do have symptoms.
Low albumin is a contributor to edema formation, as I understand it.
Correct.
Is there any point in attacking a low albumin level if you also find it? I would guess these people might have that. They may not be very healthy in the first place.
So the question is, just for everybody on this side, is low albumin may cause edema, so should we attack low albumin as well as part of this?
Well, of course, some of the classic low albumin states would be liver failure and renal failure. I haven't studied liver failure, but we certainly have studied renal failure. And of course, these patients are on dialysis and they have their fluid shifting constantly with each dialysis session. We do know that in the renal failure population, if you dialyze patients at night, either peritoneally or with hemodialysis, and for example, you take off the same amount of fluid during a 6 to 8 hour period at night versus during the daytime, sleep apnea gets much better. And the second part of the grant we got is to do a study looking at ultrafiltration, where we'll take off 1 to 2 liters of fluid in patients between their dialysis sessions, measure the fluid content of their upper airway, and find out whether that is associated with improvement of the sleep apnea. Now, albumin per se, in as much as it promotes edema, then it should promote sleep apnea. Now, how you attack that, that's another question, because of course there's not much you can do in either liver or renal failure about that. But certainly that's a very reasonable question.
So question back there. Go ahead.
So I have 2 questions. First question is, if you put up your leg at different times during the day, rather than sit like with your legs down, would that help? And the second question is, if you incline your bed, would that decrease the fluid shift and also improve the sleep apnea?
Okay, so the first question was, if you elevated your legs while you were sitting, would that prevent fluid retention? It should, theoretically. I suppose that people who sit in an easy chair are probably better off than people who sit with their legs on with their feet on the floor. But nobody's ever, we haven't looked at that specifically, but that's a reasonable thing to think about. With respect to having the leg raised, the head raised in the bed, of course, we know that heart failure patients adopt that strategy anyways, even if you don't tell them to, because they're really smart. They know that if they lie down, they're going to get fluid in their lungs. They may not know that they're going to get it in their neck, but they probably are too. So in fact, we're doing a series of experiments to find out, to answer that question. That's part of the grant as well, is to find out whether raising the head of the bed or lowering the legs or both is associated with a reduction in fluid movement into the neck and lungs, and whether that improves sleep apnea. So it's a very reasonable hypothesis.
Any other questions? Okay, thank you very much. That was great. Thanks very much. Thank you. Okay, so the other suggestion is moving your ankles up and down. So flap like a bird in your chair or something like that. So I want to see you guys moving your ankles. So Paul O tells us we should walk to the buffet afterwards, So anyway, so we're getting lots of good tips. So now we have the vascular surgeons. And usually, how come there isn't a whole string of you guys coming up here? Usually there's like a troop. Anyway, I'll introduce Dr. Lindsay. He's the one that will take us through the vascular surgery section. He's professor of surgery and chair of the division of vascular surgery at the University of Toronto. Sort of the world of vascular surgery rests within his hands. All the weird and wonderful things that you hear about on the news or Google, he has some sort of hand in. He did his postdoctoral fellowship at Harvard and then also came back to vascular surgery here, and we're very thankful that he's heading our division, and he will take us through the vascular surgery component of this day.
Great, thank you very much. I apologize that I was trying to make sure that the rest of my team was here. I see that some of them have arrived while I was texting them during the question period there. So I am very happy to chair this next section, and we've tried to highlight a number of key areas of both advancement and innovation, as well as some very standard clinical problems to try to enhance your understanding and treatment of these folks. And our first session is by my colleague, Dr. Graham Rochenagel. Graham is a graduate of our fellowship program, but came from Dublin and Ireland, and he's going to talk about office-based assessment of disorders of venous circulation. Graham.
Good afternoon, everyone. Obviously, as the most junior member of the department and how things flow downwards, I'm left with the vein talk. But I'm very happy to know now that I also can help sleep apnea. I just want to assure everyone in the room I also treat aneurysms, carotids, peripheral arterial disease. And for every maybe 5 vein patients, as long as you send an aneurysm, I'll be happy to see them. Okay. So I've no disclosures for this talk. So my objectives really were to try and give you an overview of problems with the venous circulation. And we're going to talk about problems you guys probably see every day in your clinic, and we're going to try and give you some direction of how these patients should be managed, and hopefully answer any questions you have at the end. So we're going to talk about varicose veins, we're going to talk about chronic venous insufficiency, and a bit about thrombophlebitis. So while it's not a very sexy talk compared to some of the stuff you're going to see later on, it is a big problem, and you probably appreciate that a lot more than we do. And it is a large number of people are inflicted by this problem, and it causes significant morbidity. So just briefly, a bit of venous anatomy. There's 2 systems of veins in the legs, the superficial and deep. The superficial one is made up of the great saphenous vein. Somehow my slides seem to have got out of skew, but essentially the great saphenous goes along the medial aspect of the leg and joins at the inguinal ligament. The small saphenous vein comes from the back of the leg and joins into the popliteal vein just behind the knee. You have these perforating veins then, which contribute between the deep and the superficial system. And also then you have your deep veins, which nominally follow the arteries, and they're the ones that can have problems with deep venous thromboses, and they're the ones that go under the inguinal ligament to bring your main venous circulation back to the heart. So when we talk about varicose veins, what we're not talking about is the small flush veins or the small reticular veins. We're talking about superficial, dilated, tortuous, elongated superficial veins. And they can be due to incompetence of the saphenous vein, either the short saphenous or the long saphenous veins. And they're a very common condition. Often they say that it occurs more often in women. People don't really know if that's true or whether women just present more with varicose veins. They tend to be familial, most commonly occur in women and are worse in pregnancy. And why does it happen? Well, there's a system of valves in the superficial veins, and what happens is these veins become incompetent, and then with the orthostatic pressure, the superficial veins get elongated and dilated. And the etiology is twofold. The majority of these is due to reflux disease, essentially where the valves become incompetent, but also can be due to venous obstruction, and that can reduce or result in features like the post-thrombotic syndrome when it's due to deep venous thrombosis. So the risk factors for varicose veins, age, the older you get, a bit of wear and tear, certainly that can cause veins to malfunction. Women more so than men, there are some hormonal reasons. Progesterone relaxes the venous walls and they're more likely to get varicose veins. Also pregnancy, when the baby lies in the pelvis on these veins, can cause venous insufficiency. And also HRT or OCP can also increase the risk of varicose veins. Genetics, which I'll talk about shortly. Obesity increases venous hypertension, and standing for long periods of time, prolonged immobile standing impairs venous return. People talk about the strong familial component. It's not well studied, but if you look at the available evidence, if you look at twin studies, 75% of identical twins, if one of them has varicose vein, 75% of the other twin will have it, 52 for non-identical. If both parents have varicose veins, unfortunately, there's a very good chance that you're going to have varicose veins. And if one parent is affected, 25% of men and 62% of women. The majority of veins that may come into your office are often cosmetic concerns, but they can cause a real morbidity. People can complain of burning, swelling, itching, and then they can also get ulcers, bleeding, and even superficial thrombophlebitis. So when I see a patient for the first time with varicose veins, really you want to get a sense of how much these veins are affecting their quality of life. You want to really take a good history about previous venous complications. You want to know if they've ever had a question mark about having a deep venous thrombosis, because that really will potentially affect your management going forward. You want to talk about their desire for treatment, their comorbidities, and you want to rule out secondary causes like DVT. In terms of the examination, we're fortunate that we have a duplex lab on site, so anyone who's referred for varicose veins, I send them for a lab study first. But in terms of examining someone in the clinic, you want to get them to stand up. You want to inspect the pattern of their veins, and that will give you a sense of whether it's a long or short saphenous. You want to check their pedal pulses. You want to look in their groins to make sure they don't have a big saphenopharynx, which would be a dilated vein in the groin. In terms of practical tests you could do, the Trendelenburg Test is one that is well recognized in books. It's not something I've done in many years, I must confess. It's where you put someone flat on the table. You can press on the saphenofemoral junction just medial to the femoral pulse, get them to stand out. If their varicose veins don't fill up, that means their main incompetence is at the saphenofemoral junction. Or if they do, it may be lower down through perforators, and you can just manually go down and continue down till you find the site of incompetence. More often, if you have a Doppler in your clinic, it certainly is very helpful. If you put a Doppler on the vein and then press the calf, you should hear a shh. So less than kind of 1 second. If it's shh, shh, that means the veins are incompetent. And if you ever get a report back from a lot of the labs, they'll talk about less than 0.5 seconds, greater than 1 second, and that's what they mean when they do the incontinence test. There are classification methods for varicose veins. You've got the no visible or palpable sign of venous disease. You've got these small telangiectasias or reticular veins, and then you've got your classical varicose veins. And really, it's class 3 to 6 are the ones that present normally to us for treatment. Ones who complain of edema and the symptoms towards the end of the day, skin changes associated with venous disease, which we'll go through shortly, and then also with ulcerations, active or healed. So in terms of my practice, when someone sends me a referral for a varicose vein, I like to get a duplex scan. Maybe it's a bit of paranoia, but I really want to get a sense of what's going on with the deep veins. I am reluctant to perform superficial surgery in kind of borderline varicose veins with someone who have deep venous incompetence. There's other tests which have been bandied about, but I think if you have a good duplex scan, I think it gives you all the information you need. And it's a very sensitive and specific test. So when I see a patient and I've gone through the investigations and confirmed that they have superficial venous incompetence and they want some type of treatment, I talk to them about 3 main methods of treatment. First is conservative, which really revolves around graduated compression stockings. This is something they wear knee-high. They can wear while they're standing around during the day, and it can help their symptoms significantly. Leg elevation can be added to this, and people also, I get them to raise the end of their bed at night, and certainly this can help. In terms of the 2 interventions I talked to them about are endovenous treatment and venous surgery. So when we talk about the compression stockings, as I say, they're elastic stockings that are graduated in pressure. There's 2 main prescriptions I give patients. One are the kind of grade 2, which are 20 to 30 millimeters of mercury for edema and maybe DVT prophylaxis. They're the lighter compression. If someone's got very bad varicose veins or has had a history or active ulcerations, certainly they need a higher grade of compression. However, a lot of people don't do well with compression stockings. They can be difficult to put on, especially if someone has rheumatoid arthritis or, bad knees. 50% of them are unable to put them on alone, which is a big problem. There are now neurostockings that come on that actually come as wraps, so they're much easier to put on than the standard stockings. And there's a lot of non-compliance. People come back and say, well, have you tried compression? Oh, yes. But, the majority of people don't leave them on for the appropriate length of time. There's been an advent of the last, decade of more minimally invasive treatments for varicose veins. Now, currently, none of these interventions are covered by OHIP. The rule I've read is that there's no cosmetic vein surgeries covered by OHIP. So these currently are in the realm of the private clinics. I personally don't do it. I'll happily refer people on to get an opinion for those people who do, but on average it costs between $2,500 and $4,000 a leg. So it is a very expensive treatment. The advantage is obviously it's a clinic-based procedure. It's done under a bit of local anesthetic. People walk in, they walk out. But what they can only do really is treat the long saphenous incontinence. They can't treat any of the major below-knee veins. There's a slew of different options. The main ones coming through in terms of the best efficacy are the radiofrequency ablation and the laser. In terms of the mainstay of surgical option is the phenofemoral junction ligation, stripping of long saphenous, and multiple avulsions. And one of the reasons you need to understand is why there's such a slew of different options is that, unfortunately, surgery isn't that good a treatment for varicose veins. When I can send someone for varicose veins, they need to be aware that 40%, so 4 people in 10, will have some recurrent veins within 5 years. That's the statistics. Now, it's not the veins that we've taken out because they're in the bin, but people have thousands of veins in the body, and I keep telling the patients that they're vein-making machines, and unfortunately, there's a good chance they might get them back. But oftentimes, if they're symptomatic, once you take care of the long saphenous, usually if they get recurrent veins, it's not as bad in terms of symptomatology. So in terms of how we do varicose veins, because I'm sure you see these patients come into the clinic a couple of days after we've stripped them and they're bruised and they're battered, and you're wondering what exactly we did to them. We make an incision just medial to the femoral pulse. And what we do is we identify the saphenofemoral junction. And one of the key things I tell the trainees is that you cannot divide any of the side branches until you see that junction, because unfortunately I have seen cases where people have divided the femoral vein, which is a disaster. So until you see that saphenofemoral junction, you cannot divide any branches. Once you've seen the junction, you tie off the branches, tie off the saphenofemoral junction, and disconnect the long saphenous. Then we insert a stripping device, which is essentially a long piece of plastic, and we feed that down through the vein, and we're trying to get it down to just below the knee. We don't strip below this area because the veins below that can run very close to the nerves and people can get significant neurological complications. So usually we go just below the knee, and you can see we feel for it under the skin, make a small incision, and grab the other end of this stripper. At this stage then we have access at the top and just below the knee, and there's a little head. I'm not sure if you can appreciate it. Just in the on our hand there, it's a little small head that you attach, and that essentially you pull from the lower end and you avulse this whole length of vein. So at the end of after the end of the stripping, you've basically avulsed the whole length of long saphenous. Now obviously that's why people get significant bruising along this section, and often can get a bit of thrombophlebitis because you get a length of a canal essentially that can fill with a bit of hematoma, and that's why we try and do our best to press, sometimes using adrenaline just to reduce the bleeding, but they can get significant bruising and thrombophlebitis along that section. Then in terms of the avulsions, we make little small stab avulsions, and we take out the other smaller veins. In terms of complication, in terms of surgery, you can get a significant wound infection, about 3 to 6%. You can get nerve injury, which is about 1 to 2%. Hematoma is quite common. We try and minimize that by putting people in a compression wrap. Then also laser ablation, radiofrequency also have their complications. Sclerotherapy is famously for people, unfortunately, have had strokes following sclerotherapy, where they've had embolization through a patent foramina valle or a VSD or an ASD, and there has been cases of significant neurological complications. In terms of the evidence, currently the evidence supports, basically they're both kind of equal in terms of minimally invasive versus surgical, and we don't have the long-term evidence for the laser and the radiofrequency as yet, but it's basically going to be driven by consumer demand. So moving now on to chronic venous insufficiency. This is kind of a term used to describe the changes that take place in the tissues of the leg due to long-standing high pressure in the veins. They can have pain, swelling, edema, skin changes, and ulcerations. Now, these can be in the presence of valvular incompetence, either superficial or deep. In many patients, they have varicose veins, but also can happen in the absence of varicose veins. The risk factors for CVI, deep venous thrombosis certainly is one of the bigger ones. All the rest of them really are similar risk factors that we discussed for varicose veins, but people who have deep venous thrombosis, because they get incompetence of their deep system, are very prone to getting chronic venous insufficiency. And these are the people really who are miserable, and they get very bad complications. And it's one of the things that once a person is diagnosed with a DVT, they should really be put in compression stocking straight away to try and minimize these long-standing complications. The things they complain of are hemosiderin deposition, is that brownish discoloration you get classically over the medial malleolus. You get lipodermatosclerosis, which is a thickening of the skin due to chronic inflammation, and they classically get the inverted champagne bottle calves, where at the ankles are very thin, branching out to a bigger calf. Other things they get is a venous eczema, swelling, and ulcerations. Again, the ulceration is classically over the medial malleolus, where there's the gaiter area of venous plexuses. And it has a significant impact on people's quality of life. And these people have to go regular dressings, get infection, pain. And also it has a significant economic cost. And the bigger the ulcer, certainly the bigger the economic cost. So what causes these venous leg ulcers? So there's a number of different theories. No one really has come up with the one definitive treatment, but there's ones or theories that involve that you've got active ongoing inflammation that cause the breakdown of the tissues. You've got deactivation of growth factors which prevent healing of the tissues or maintenance of the tissues. So it is a multitude of factors, but it's primarily due to high venous pressure. What happens is blood products get pushed out into the superficial skin and you get a localized inflammatory reaction. So when you see someone with chronic venous insufficiency or venous ulcer, what kind of assessments do you need? Certainly it's important to identify, first of all, what type of ulcer this is. So you need an accurate history and physical examination with special reference to venous and arterial disease, so diabetes, rheumatoid arthritis, and also you want to get a history of any previous DVTs. You always need a formal assessment for arterial circulation because the treatments for these patients primarily revolve around compression. And a duplex scan of the venous system will help in terms of managing these patients. I always tell the residents there's 9 things you should describe about an ulcer: the site, the size, the shape. You want to know about the edge. The base is what it lies on. The floor is what you see. The surrounding skin, the pulses, and the lymph nodes. So you want to kind of get a overall look at the ulcer, how long it's been there. Always beware of the chronic venous ulcer that can turn malignant. And you also want to, so this is a kind of a marginal ulcer, which if an ulcer is not healing after a significant portion of compression tissue, consider a tissue biopsy. So again, important to look for any underlying arterial disease, and then you want a good duplex examination of their venous system. So once you've completed that, the mainstay of treatment, providing they have no arterial insufficiency, is 4-layer compression bandage. And this is classically the Charing Cross 4-layer compression. So these are bandages that can be changed at 5 to 7 days or more frequently depending on the amount of exudate from the ulcer. With these in place, 50 to 70% of pure venous ulcers heal within 12 weeks. But it's about patient compliance. The patients have to be educated about elevating the limb and doing all the things that will help heal venous leg ulcers. Diet is important. Supplements, zinc, magnesium also can help. And ideally, the best results have come when they've been associated with bed rest, but obviously that isn't practical in a lot of situations. The surgical involvement then, it depends really on the pattern of venous insufficiency. And I would break these population into 4 areas. You've got superficial venous reflux only. Absolutely, people will benefit from surgery. If you've got deep venous reflux only, no. You will make them far worse if you strip their superficial system if their deep system is the only one that has reflux. If you've got mixed superficial and deep, the latest evidence is that if you deal with the superficial system, you can actually help them heal and prevent them reoccurring. And if you've got an occluded deep venous system, absolutely, again, not a candidate for surgery. So this is the Eshkar study, which there's a slide in your system. And what basically it shows that if you do surgery and compression, certainly the recurrence rate is less. The healing rates are pretty much the same. It's important that it's a multidisciplinary care. The patients have to be educated, and that's the only way you can get successful healing of these patients. So just briefly going on to the last topic, talk a bit about thrombophlebitis. Again, it's something you probably see time to time in your clinic. So when we talk about superficial thrombophlebitis, it's a non-infective thrombosis of the vein. So To treat these people, it's not an infective process, it's an inflammatory process. There's different types of thrombophlebitis, but the one we're probably going to talk about is people who've got superficial varicose veins and get thrombosis. And it can occur in any superficial vein, primarily because you've got stasis there, and you can get thrombosis. There's a number of risk factors, obviously varicose veins. People who have sclerotherapy, that's what you're actually doing. You're causing a localized thrombosis. Venous insufficiency, hypercoagulable states. Always be aware of people who have multiple thrombophlebitis, that they may have a malignant condition. These people complain of erythema, pain, and often get this palpable cord over the vein, and this is obviously a very dramatic picture of one. And the diagnosis classically is clinical, but you need to always be aware of the one that migrates up towards the saphenofemoral junction, because they can migrate into the deeper system and cause a PE. The treatment options oftentimes are mechanical. You can put them in a bit of compression, topical treatments, systemic nonsteroidals, anticoagulation, and then the ones that you need to be aware of, the one that migrate up towards the saphenofemoral junction, they may require relatively urgent ligation and stripping. So in terms of the one that goes near the junction, there is a significant incidence of DVT from extension. It's about 3%. It's important that if you find that thrombophlebitis is migrating up the leg, to see them at a relatively short interim period and maybe repeat a duplex. The kind of latest treatment primarily now is to start systemic anticoagulation at that point and prevent propagation of the clot. But definitive treatment is ligation and excision of the infected vein. So thank you. I hope I haven't bored everyone, and thank you for your attention.
Well, that was very good, Graham. We're going to save questions for the question and answer period in the panel discussion in a few minutes. So please either write down your questions or jot them down and be ready to hand them to either to me or to Peter. So the next thing we really wanted to do was highlight, in fact, sort of the team approach that ourselves and our interventional colleagues have at the Toronto General Hospital. You're going to hear that we work closely together with our interventional team, and in fact, my colleague, Dr. George Oriopoulos, who's going to speak to you next about some cases, has spent the last year, completed in June or July, he spent a year retraining to be an interventionalist, so that we now are kind of intermingled. And I think that this team approach is an important aspect of the care that we provide, both in diagnosis and therapy for the patients we treat at Toronto General. So Dr. George Oriopoulos is going to talk to you about some case-based vascular surgery cases. George?
Thanks, Tom. And I'd also like to thank my other division chief, Dr. Tan. These types of cases, Dr. Lindsay had asked me to present really unusual things that may not be treated at every institution, that highlight some of the things that challenge us the most. So a series of less common vascular problems, and to illustrate a role for multi-specialty approaches. And I'm going to show you a range of what I consider truly minimally invasive approaches to difficult problems and maximally invasive approaches to bridge the spectrum. When we have combined services working on a patient, we usually have complementary skill sets. And this is one of the things that I think we do better at UHN than other places, where we talk to each other. We have rounds together, and we can come up with creative approaches to challenging or unusual problems, because people send us things sometimes that we haven't even seen outside of a textbook, or that you may decide to include in the next textbook. I find I worry about some things that my colleague Dr. Jaskolka or Dr. Tan may not be worried about, and things that they may worry about don't bother me as much. So when we're coming to work to deal with these difficult problems, it's a way working together to moderate stress. And in the end, it really does make for a much more pleasurable time where you feel like you've done everything you can for someone with truly terrible things happening. Now, the office does look different. And this is what I won't say the operating room of the future, because this is the operating room now, and that's Dr. Roach-Nagel. He's a little far away in that shot. But this is our multi-purpose operating room, the first of many such rooms that we'll be seeing. And in this operating room, which is the size almost of a football field, you could have a cardiac pump team. We certainly have fixed angiographic equipment and a CT scanner in the room. And in this room, we can do conventional open surgery if we had to, purely endovascular treatments, and hybrid techniques that use a combination of the two. And just imagine where we have a ruptured aneurysm in the emergency room, or someone we even don't know, we suspect they have a ruptured aneurysm. The safest place for that type of patient is in an operating room. So bring them up to the room, scan them, make the diagnosis, and we have all our equipment to do either open surgery or endovascular treatment for this patient in this room. So the first case is that of a pretty direct approach to a difficult and unusual problem. I was called to Mount Sinai's coronary care unit for a young woman who was recovering 1 week postpartum with bilateral pulmonary emboli. And that by itself isn't so unusual. We know that pregnancy is a risk factor for venous thromboembolism. But she had something weird in her history in that she had a myocardial infarction secondary what she was told was a coronary dissection at the age of 20. And she was from the Middle East originally. So I didn't really have access to any of her previous records. There was no family history of any unusual collagen vascular diseases. And the reason I was called over were some very unusual findings on her CAT scan. So here is her pulmonary emboli, and these would be a fairly typical appearance on a CT pulmonary angiogram. But she was noted to have a 1.4 centimeter diameter splenic artery aneurysm. And we know that this is a very dangerous entity in pregnant patients. If we have a pregnant patient who presents with shock, and it's not from a ruptured ectopic. You know, when I was a general surgery resident eons ago, we were taught if we opened this kind of patient through a lower midline incision and we saw the blood coming from the upper abdomen, we should worry about this. And she had some other problems. She was noted to have a celiac artery dissection. And there was no history of abdominal pain or back pain that I could correlate with this image. At the same time, both of her external iliac arteries, you'll notice they look like they're having two lumens. She's had external iliac artery dissections. So at this point, she was recovering from her PEs, looked good. She wasn't on any high FiO2 oxygen. I thought 1.4, and she's just delivered. Maybe I can defer this problem, and I'll see her in follow-up because she's got something unusual happening. She has probably some form of collagen vascular disorder. So she presented to the emergency room 10 days after she left. She had a CT scan, and she was told, there's no rupture, go home. And she was having pain. Well, you'll remember I told you the aneurysm was 1.4 centimeters. This is 2.4. She called my office. She said, can you please look at the scan I had when I was in the emergency room last night? And she was having pain, and this was a 2.4 centimeter aneurysm, a centimeter's growth in a week. So now I have a problem. This is a patient at imminent risk for rupture and death. The age of 33, new mother. So I presented her at rounds. And while surgery is an option, I wasn't sure I wanted to get that close to her blood vessels. And at some point, with all of her other vascular abnormalities in her young life, she probably would require abdominal surgery or vascular surgery for either an urgent or elective problem. So I really wasn't that keen on operating on her. In terms of using an endovascular approach where we'll put a covered stent or coils through that aneurysm, we would have to go through her femoral arteries, through her dissected vessels, through her celiac artery. And as I was thinking that she could have, her collagen vascular problem, this would pose some additional dangers, additional areas we'd have to treat, and a long way to get to the aneurysm. So Dr. Jaskolka and myself had taken this patient to the interventional suite, and we could see this aneurysm on ultrasound behind the spleen. And you'll see next we've stuck a 22-gauge needle through the spleen into the aneurysm. And this avoids surgery. This has avoided a transarterial route through her dissected arteries to get here. We took some pictures, and then we deployed a series of microcoils. And we finished off with a little bit of crazy glue on the way out. So she had no further symptoms, and she had a follow-up CT scan that showed the aneurysm was thrombosed. But she underwent genetic testing that showed she had Ehlers-Danlos type 4. These patients, if you do an arterial puncture on them, their risk of death from an angiogram can be as high as 12 or 15%. They actually recommend if you put a catheter in this patient's artery, you should take it out surgically. They have a defect in their collagen. It's either inherited or sporadic, and it's a defect in the type 3 procollagen that's coded for the collagen 3A1 gene. 1 in 50,000 patients will get this, and the median lifespan of these patients is 48 years because they die of vascular ruptures, dissections. Occasionally they have GI perforations, and they have an inherent weakness of their blood vessels. If we operate on these patients, the arteries tend to fall apart, and we have to use various measures to try and cobble them together. And the recommendation is, unless you have an imminently life-threatening situation, don't touch these patients. So I think we had a fairly good result. She went for some genetic counseling. She has a medical alert bracelet now, and because of her husband's job, they've relocated back to the Middle East. Splenic artery aneurysms, I see more garden variety splenic artery aneurysms than in this patient who don't have all those other abnormalities. And they tend to occur 4-to-1 prevalence in women compared to men. Median age that we see them is 52. They tend to be incidentally discovered. The mortality with rupture is high, 25%. And the indications for intervention in general are more than 2 centimeters in diameter, expanding, or symptomatic. Now, if I have someone in their 70s and 80s and their aneurysm is really circumferentially calcified, indicating it's been that way for a long time, I'll tend to watch them, even if they're around that 2-centimeter mark. But the highest risk group are women of childbearing age and even higher risk pregnant patients. So if they rupture during pregnancy, there's an 80% risk of maternal loss and a 90% risk of fetal loss. So we like to find out about these things. And as I mentioned earlier, endovascular approaches are the preferred approach. So let's go the other direction, going from a 22-gauge approach to a bad problem to the exact opposite, maximally invasive surgery. So I had a 54-year-old dance instructor who ran his own studio. This man had won the lottery. He'd had an anonymous, unrelated living kidney transplant. He'd won the lottery. And his transplant physician had noticed that he had continued hypertension, a rising creatinine since his transplant 10 months earlier, and severe short-distance thigh and buttock claudication. He no longer was able to run his classes in his business. He had absent femoral pulses, and on more direct questioning, he also had impotence. So absent femoral pulses, the thigh and buttock claudication, and the impotence, that's the classical Leriche syndrome we teach our students. He was sent for an angiogram of his renal transplant artery, as usually it's a problem at the anastomosis or going into the transplanted artery. And we suddenly see a normal transplant arteriogram, where what you see is the transplant artery that's going off on an angle is anastomosed to the external iliac artery on the right side, and there's no problem. Even in a different obliquity, there's no stenosis. So a little more proximally, though, we have an occluded aorta. And you see that shadow of calcium. What to do about this? So he had a non-contrast CT scan and a 2D echo, and the results of the 2D echo subsequently prompted a coronary angiogram. This patient, he ended up having severe aortic stenosis, which would require surgical management. So we have several goals. One, revascularize his transplant. I mean, this man is very lucky. He's a contributing member of society. We wanted to get him back to his dance studio. We wanted to revascularize his lower legs, and we wanted to manage his cardiac pathology and provide really a lasting, durable option in this young man. So traditional treatment options for his legs would be an axillofemoral bypass, where we do a long bypass from the axillary artery down to the groin. Those long bypasses are subcutaneous operations. It's almost like giving the patient another disease. They tend to occlude, become infected, not a good long-term solution. An aortic stent, well, when you'll see a CT scan, see how that might have been maybe not a lasting solution. An aortofemoral bypass would also be a challenge. When you see his aorta without contrast, this is a lead pipe. This is the situation where Dr. Rubin and Dr. Lindsay would teach me as a fellow, if you put a clamp or try to on something like this, you'll have calcium jutting out above your clamp with a tear, and the patient will die. This is a lead pipe aorta, and in different views, he's Mr. Calcium, whether we go proximal or distal. The only place I'll draw your attention to the scan on the right is his ascending aorta that has no calcium. These are his femoral arteries with no contrast. Those white areas are just calcium. So we took him to the operating room, and you'll notice I had patched the femoral artery, that little white bit in the corner. I don't know whether we have a laser pointer, but that's a bovine pericardial patch after I cored out the femoral artery, sewed the patch on, and then did a femoral bypass from the right groin to the left, and then we brought inflow down to that. So where's my inflow from? Well, it's from the chest. My friendly cardiac surgeon, Dr. Cusimano, had done a valve repair and a coronary bypass, and we had anastomosed the inflow to the ascending aorta, taking that down to the legs. And that's another view of that. We usually are not looking at bypasses in that location. So I just, in terms of teaching points for this case, we tend to think about operations or revascularization as inflow and outflow, open or endovascular cases. Inflow procedures are those procedures that bring blood to the top of the leg. Outflow procedures are those that take blood from the top of the leg distally. And our choices really will depend upon the perceived durability of the operation, or endovascular procedure, any concurrent procedures that are required, i.e. coronary bypass, aortic valve replacement, the potential lifespan of the patient and any comorbidities. And as I mentioned, the conventional inflow procedures are AXFEM, FEMFEM bypasses, and aortofemoral bypasses. And less common procedures would be based off of the thoracic aorta from a thoracotomy on the side or the ascending aorta. Case number 3 is an unusual carotid problem. So I had a 55-year-old man who came to see me for follow-up of a mild right carotid stenosis. He had already had a left hemispheric event the year before after a stroke and an aortic coronary bypass that had resulted in an occluded internal carotid artery. If the internal carotid is occluded, no longer are we going to get emboli to the brain. So I'm not worried about that side, but we should keep an eye on the other. Interestingly, he'd had 2 previous aortic aneurysm repairs. No one had really noted that his occluded carotid on the other side was an aneurysm. So when my own ultrasound showed very sluggish flow through the remaining carotid on the right, we obtained the CT scan. These are not eggs. These are aneurysms. And I apologize, it doesn't project very well, but the top of the aneurysm on the right side has a double S for the internal carotid. And he's already occluded the other side. This is, again, a young man, very sluggish flow in this. And he stroked when he occluded the other side. So here we have a situation where we probably have to do something about it. Carotid aneurysms, less than 1% of all operations or procedures for extracranial cerebrovascular disease. The previous treatment, the first person was Sir Astley Cooper treating these by carotid ligation. And he learned the hard way that 30 to 60% of patients will stroke. Etiologies, well, degenerative, dissection, trauma. In the pre-antibiotic era, where people had untreated head and neck infections, the mastoid and things, these would erode into the internal carotid artery, and you could have aneurysms on the inside of the mouth or the pharynx that would pose special dangers. So Sir Astley Cooper was pretty busy. The more common situation are blowouts after head and neck irradiation and surgery that we may be involved in false aneurysm treatment. 14 to 25% of these patients will have coexisting aneurysms, which is interesting given this patient's previous history of aneurysm repairs. And most commonly, they'll have pulsatile neck masses. And the numbers, there's no large case series of these problems, 18 cases, 20 cases. And the natural history that's recorded, as far as we know, is unfavorable. They tend to have neurologic events, and any treatment is aimed at preventing further neurologic deficits. So open or endovascular repair, again, I brought this gentleman to our combined rounds. How can we treat this man? And unfortunately for him, we decided that the internal carotid above the aneurysm was so tortuous that we couldn't put a carotid stent up. So he went for surgical reconstruction. And the quoted mortality rate in the literature and combined mortality and stroke rate is 10%, which is higher than a regular carotid endarterectomy. And this guy's already occluded the other side. So I was on commit to shunting this. This is a picture of the aneurysm, which is off towards the right of the picture, and the external carotid, which is looped around those blue loops. And at the very upper portion of the picture is the internal carotid that I've controlled, almost coming horizontally and downwards with another loop. I've opened it. I put in a shunt. And what we've done is effectively, I cut the aneurysm off the bifurcation of the carotid and patched it. Then I divided the external carotid, which he wouldn't miss, and we had so much extra internal, I brought it down and sewed the external to the internal. And now he periodically comes to see me for his carotid follow-up, and he's fine. He didn't stroke. Case 4. This is one that my colleague and teacher, Dr. Tan, and I had attended to. She's a 79-year-old woman who came to the hospital on one of our critical intake days, and she'd already had an aorto-bifemoral bypass done at an outside hospital, and she'd seen another surgeon who was considering a revisional aortic surgery. Unfortunately, she presented before she could be revised and had occluded the whole graft with 2 ischemic legs now. So she was transferred emergently to Toronto General. She had bilateral pain at rest of sudden onset, sensory deficits, and when I went to see her, she had difficulty with dorsal and plantar flexion of her legs and her ankles and moving her legs. So she had immediately compromised and immediately threatened legs. And not wanting her to get any shorter, we had to do something. So she had absent femoral pulses. She had a diagnosis of an acute aortic occlusion, which is a surgical emergency. Sometimes these patients present without the history of a bypass, and they present predominantly with neurologic symptoms. I've seen patients who go for CT scans for an acute disc or a cauda equina syndrome, and on one cut, they notice an aortic aneurysm that's thrombosed or an aortic dissection. And that prompts a reevaluation of what the diagnosis is and can really delay a terrible problem beyond the point of no return. And this is just to show you how acute limb ischemia is categorized, and she would be in the to be immediately threatened category on the basis of her neurologic impairment. So just as an example, this is a viable foot with no neurologic deficit. They'd have an audible Doppler signal at the ankle or on the top of the foot. This is a threatened leg with no audible Doppler signal, a partial neurologic deficit, so the leg is not completely paralyzed. And this is the kind of consult I get to go and pronounce the leg. I can't even dorsey or plantar flex the ankle. There's a doughy feel to the calf. The muscles are tense, maybe tender. There's absent capillary return, not even a venous Doppler signal. And these patients, when they present acutely, they usually have the 6 Ps we teach our medical students: pain, pallor, pulselessness, paresthesias, or poikilothermia. So treatment options, normally, we'd consider a redo aortic procedure, or a thrombectomy of the graft to see if we could get it going, or an axillobifemoral bypass, where if I've got both groins open and I can't get the aorta going again to bring inflow to the top of each leg, then I borrow inflow from a shoulder. And I usually don't have time to do any kind of preoperative cardiac workup for this patient, so a subcutaneous operation isn't that stressful. I'm not clamping her aorta, giving her a big afterload, so this is a consideration. But we thrombectomized her groins, and we couldn't get inflow, so Dr. Tan and I had decided to do something else. We were able to pass guide wires through the old aortic graft that had been occluded into the aorta above the area of the occlusion. We ballooned it open and stented it open. And then we have our completion angiogram showing that we now have established flow. So 3-4 years ago, I would have been doing an axillobifemoral bypass. Now she has a reconstructed aortic bifurcation and would be expected to do pretty well and has saved herself redo aortic surgery. And she went home 4 days later. So really, I want to talk about the importance of both human and material resources in dealing with unusual and rare vascular problems. And really, this especially includes talking to each other, putting our heads together in our combined rounds. This is probably the most powerful tool we have for dealing with difficult problems here at the UHN. Open surgery is still used. Sometimes we'll be doing hybrid procedures with a combination, open and endovascular means. And really, despite advances in all of our imaging, good clinical decision-making is still, essential.
All right, thank you very much, George. Now we're going to have to get the AV guys up here because Dr. Jaskolka is going to run off his Air Mac here if it actually has legs. So Dr. Jaskolka is part of our interventional radiology team, and he has joined us and has an expertise in MR, but is also an interventional radiologist, and is going to talk more about endovascular therapies as opposed to open therapies. So Jeff, take it away.
Usually. Excellent. Thank you very much. And thanks for the opportunity to be here this afternoon to speak to you a little bit about my job and what I think is fabulous about sort of modern medical care for peripheral vascular disease. So by way of introduction, I think that angiography and endovascular therapies have represented a major revolution in vascular care, as you've already had a bit of exposure to in Dr. Oriel-Hoppus' previous talk. And it's an incredibly valuable treatment option for patients with peripheral vascular disease, along with many other things. And the reasons that we like it and the reasons that it's taken hold is that most of the procedures are minimally invasive, and they tend to be highly effective. In the context of peripheral vascular disease, the main applications are treatment of stenoses, treatment of aneurysms, or treatment of hemorrhage. And it's important to note, and I think you've already gotten the sense of this, but this is not something you do in isolation. You need to be working in conjunction with your vascular surgery colleagues, both as a referral base and also to bail you out when you get into trouble. So with that said, we'll move on. So the objectives are in your handout, but basically I really just want to give you a bit of a flavor of the kind of stuff that we do and the way it fits into the management of patients with peripheral vascular disease. And I'll start off by saying that basically almost everything we do in terms of endovascular treatment is based on the Seldinger technique. And this was a paper that was published in the 50s. And basically the idea is of how you get into arteries and are able to treat them. So in this first picture here, you basically see a little needle going down into an artery. And then over here, you see a little wire going through that needle into the artery. Then basically you take out the needle but leave the wire in place as your highway or your access into the artery. And over that, you push some sort of device, in this case a catheter, that then gives you access to an artery through which you can do intervention. And almost everything we do is based more or less on this technique. And here's a quick picture of some of the catheters that we use. A catheter is basically just a long, skinny, sterile, calibrated plastic tube. The standard size is on the order of kind of 1 to 2 millimeters in diameter. You can see here on the top right picture that they come in a variety of shapes, and each shape has a kind of different application depending on what you want to use it for. And this is just a magged up view here. This is the hub of the catheter, which is a standard lure lock, and you can inject contrast or place wires through there. And this is a tip of a sort of typical hockey stick shaped catheter that we can use to steer through the arteries and select various vessels. So now we're going to start with the cases. And most of my cases will be a little bit more vignette-like than the ones you just heard. And they're all going to have quite a typical history. So first of all, the first case is of a 74-year-old woman who has short-distance right leg claudication. And this comes on usually within 3 to 5 minutes of walking, resolves with rest, but is extremely lifestyle limiting because she loves to walk. Her past medical history is quite typical. She has coronary artery disease, hypertension, hyperlipidemia. She's a long-time smoker. She takes aspirin. She's on a statin, an ACE inhibitor, and a beta blocker. So her first imaging was a Doppler ultrasound, which showed a dampened waveform in the right common femoral artery and a decreased ankle brachial index on the right side to 0.7. So her first test was a magnetic resonance angiogram. And basically, you're looking here, you've got the descending thoracic aorta, a small abdominal aortic aneurysm, the right common iliac artery, and as you work your way down the right external iliac artery to here, there's a severe short focal stenosis. And this is just a slightly different rotation of the 3D angiogram showing how severe the stenosis is. And because of her multiple comorbidities, it was elected to try to treat her in an endovascular way. And this is sort of an ideal lesion for that because it's short and focal, which tend to respond best to angioplasty. So here now on the left side, you've got a picture, again, a magged up view of the MR angiogram. On the right side here, you've got the conventional arteriogram, which confirms the severe stenosis. And the treatment for this is angioplasty. So what we do is we're going to cross through that stenotic segment with a wire, and then over that wire, we're going to place a balloon. So it's a catheter with a balloon mounted on it. And as we inflate that balloon, we stretch open the artery. We cause kind of a controlled dissection of the artery that hopefully remodels and leaves the artery open. So here are some pictures from the procedure. We've got a balloon partially inflated, and here you can see it's constrained. We call that a waist, which is where the stenosis was. And then we managed to completely inflate the balloon and disrupt that waist, opening up the artery. And in this picture here on the left side, you've got the stenosis before treatment. On the right side, after treatment, you've basically got a totally widely open artery. And this patient did extremely well. And